Hello, my name is Kerry Darden, and I am the Vice President of Education for MGPHO, the Medical Gas Professional Healthcare Organization. And this presentation is just a review and also some recommendations on COVID-19 and the impact that it's having on medical gas systems around the country. When the outbreak first started, the MGPHO board met and decided that we wanted to pull together our collective resources and expertise and try to put something out to the hospital community that could hopefully be helpful. So very quickly, I just wanted to thank the board of directors for their contributions to making this possible. Also the MGPHO membership, who we polled to have questions that we could address as part of this presentation. And then a special thanks to Bob Sutter and Mark Allen. These are two of our special experts at MGPHO. Bob Sutter is a special expert primarily on bulk oxygen systems, and Mark Allen is a special expert from Beacon Medeiros, has a lot of expertise in designing medical gas systems from the ground up. All right, so where are the places that you really need to watch for at the bulk oxygen source? These items that you see on the right are items that we would recommend actually adding into a daily rounding process, for someone on staff at the facility. So someone in engineering, someone in facilities management, someone that can, preferably the same person that can go look at these things each day and will be able to notice if there's been any major change. So what are the things that we're talking about at the bulk oxygen site? Primarily, the number one thing is the vaporizers themselves. These are the large aluminum structures that sit somewhere on that bulk oxygen pad typically. They have fins on them, and then in most cases they're going to be just heated by ambient air, so that as the liquid oxygen is drawn out of the tank and it passes through these vaporizer coils, the ambient air around the fins, around the vaporizer itself, causes that gas to vaporize, or causes that liquid to vaporize into a gas. What happens whenever you get excess flows is that the ice buildup, the vaporizers themselves will become iced over. They'll experience a large buildup of ice, and as that ice gets accumulates more and more, the flow that's allowed to go through those vaporizers will the rated flow will go down. So if they're rated for just say 100 standard cubic feet per hour, typically they're going to be more than that. But if they're rated for 100 standard cubic feet per hour, that flow could get cut in half or even by more, as if the ice on the vaporizers builds up very much. Another thing to check for each day is going to be the liquid level gauges. These are going to be located on the primary supply tank and on the reserve tank, provided you have a cryogenic reserve or liquid reserve. Also the pressure gauges, the tank pressure gauge, as well as the final line pressure gauge. And then any signs of leakage or unusual icing, definitely keep an ear out whenever you're on the pad to see if you hear any hissing that sounds abnormal. Try to locate where that might be coming from. We'll show you some other ways that you can check for leakage, some indicators that you might have a leak. I'll show you in a later slide here. And then as far as how often to do these, we are recommending daily right now, at least once a day. However, if your facility is in a situation, if your facility finds itself in a situation that call for doing this more frequently, you may have to go to twice a day or possibly even 3 times a day every 8 hours. So far, for the majority of facilities, we've seen that once a day has been fine, but for facilities that are experiencing a extremely high ventilator load and other just demands on the oxygen system as a result of COVID-19 patients, you may end up having to increase your frequency of rounding. Just keep that in mind. So here's some pictures of a vaporizer with what we're calling normal ice buildup. You can see on the left-hand side of that vaporizer, on the left picture on the left side of the vaporizer there, you can see the fins do have ice from the top to the bottom, but you can still see them defined. The fins, the definition of the fins themselves is still pretty obvious. So we would call that a normal ice buildup. You shouldn't have anything to worry about there. Here's another vaporizer that is showing significantly more ice buildup. On these, you can see that you can't even see about a quarter of the fins. They're completely obscured. This does not necessarily mean that you're going to have a problem getting oxygen in the building, because you can still see a good portion of the vaporizer. But at this point, this would be a good time to go ahead and contact your bulk service technician, your bulk oxygen supplier, and let them come out to assess the situation. If you have a camera phone, most people do now, a great idea is to get the cell phone number, or a number where you can get a picture to your bulk service technician, and send them a picture like this if you suspect that you may have too much ice, or if you just don't know what the normal ice level looks like on your vaporizers. It's a great idea to go ahead and send a picture of where you're at currently to your bulk service technician, so they can tell you kind of where you stand now, and you can use that as a baseline for rounding in the coming days. Here's some more extreme examples of vaporizer ice buildup. On the far left, you can see that you can't even see the base of the vaporizer, so that is not a good sign. You definitely do not want to see icing going down to the ground like that. The one just to the right of that is completely encased in ice. Obviously, that's also an issue. Same thing with the one next to that. So what are we talking about whenever we say watching for icing in unusual locations? The primary place that we want people to keep an eye on is the pressure builder vaporizer, which typically is located underneath the tank. I will show you a picture of that in the next slide of where that might be found. So what does it mean to watch for icing in unusual locations? One of the primary points that we're talking about whenever we mention unusual locations would be inspecting the pressure builder vaporizer at the same time whenever you're looking at the other, doing the other rounding for the other vaporizers on the system. There's a picture here showing you how a pressure builder actually iced up below a tank in this case. So any kind of excess icing you see at the pressure builder assembly, which normally will be located at the bottom of the tank, that'll be one of the first places you could possibly lose flow or have your flow restricted going into the facility. Inspecting the liquid level and tank pressure gauges. These are just some pictures to show you exactly where these things are located and what they'll look like. These were items number 1 and 2 on that original daily rounding checklist slide. You can see on the left-hand side of the picture, that's the tank pressure gauge. Normally it's going to be mounted around where the liquid level gauge is at, and the liquid level gauge will most likely be a large circular black gauge mounted right on the front of the liquid vessel itself. You can see that on the right-hand picture. We have showed you a reserve tank as well as a main tank. The liquid level gauges sitting right on the front of those, and then the tank pressure gauge is sitting kind of on top of the liquid level gauge. Inspecting the final line pressure gauge. This is another good daily rounding item to do. Log these pressures daily, kind of write them down, try to get as close as you can to get as fine a reading as you can. So this particular gauge here looks like it's reading between 52 and 53. I would write down 52.5 because any kind of change that you see, if it's trending downward, if you come out the next day and it's at 51.5 or 51, and you notice a line pressure decrease of greater than 1 to 2 pounds, then it's probably a good idea to start thinking about what steps you have in place to mitigate for any kind of low line pressure. One of the first things you might be tempted to do is just to raise the line pressure, but one caution when raising the line pressure: do not do it if you notice icing, or that if it looks like the final line regulators or gauges themselves have evidence of ice buildup or freezing. You would need to make sure you defrosted or de-iced those components prior to adjusting the line regulator. Some common places to check for leaks on the bulk oxygen pad, just to ensure that you're not wasting any oxygen where you don't need to be. One would be at the fill circuit, so that's normally going to be located near the actual entry gate. This is where the tanker actually refills that liquid vessel. Sometimes that cap is not fit on very tightly, but more often than not, it's a result of a check valve that could have possibly failed that should be in line directly downstream of where this cap is located. So that's one place to check. Also, there's some relief valves pictured in the top right-hand corner. Those do not have icing on them, but if you notice that they are frosted, especially if the ice is kind of concentrated on the relief valve itself and maybe leading up to the relief valve, that can be an indication that you're leaking gas out through that relief. And then the other spot you can check is the liquid level gauge lines. Those will frost up sometimes if you have a leak in the actual gauge circuit. Those are going to be the silver, normally some swage lock fittings that are put together coming up the front of the actual tank, leading to the liquid level gauge itself. So we've gotten some questions about what the de-icing procedure looks like for a bulk oxygen system. This is giving you a step-by-step kind of pictorial view of exactly what would happen when a vaporizer gets completely iced up and then whenever it has to be de-iced. So this is not something that normally the facility engineer will hopefully have to be performing. The hospital staff hopefully will not have to do this. Primarily, this would be the bulk service technicians doing this. However, in an emergency, if you absolutely had to de-ice it, this is the way that you would do it. Typically, the ice gets removed by pressure washer or warm water. If you're de-icing with just say a pressure washer, one of the most important things to keep in mind is that you want to start at the top and work your way down. The danger in doing that the opposite direction is that you can break loose the ice on the lower levels, and that will leave the ice on the upper levels free to fall down and hit the person that's in the process of de-icing them. So definitely always start from the top down, that being sort of zone 1 that you see, and then you work your way down to zone 2, zone 3, zone 4 until you've cleared the entire assembly of any kind of icing. One other thing to keep in mind is that if your facility has switching vaporizers or vaporizers that alternate banks, you need to defrost or de-ice the vaporizers that are offline first, and then whenever the vaporizer swaps after 12 or 24 hours, whatever that interval may be, you can de-ice the other side. The main concern is just to make sure that any de-icing happens on the offline vaporizer if at all possible. So what can you do if your facility is experiencing low line pressure for the oxygen system? One of the first things you can do is leave both final line regulators open. That will ensure that you can get plenty of flow through by going through both regulators instead of just one. You could also raise the final line regulator pressure. Just keep in mind the precautions we mentioned earlier about not to do that if there's any kind of freezing or icing on the regulators. And then also anything you can do to increase air circulation around the vaporizers by the use of large fans, just something to continue to blow air through the vaporizer at a greater rate. That'll help keep the icing down. Whatever you can do to keep the icing off of the vaporizers or to reduce the icing level will help you with the flow and maintaining line pressure. One thing to keep in mind, you never want to go out there and try to knock the ice off with any kind of tools or hammers or anything like that. If you're worried about heavy icing, our main recommendation is definitely going to be to contact your bulk oxygen supplier and follow their instructions. Here are some steps for raising the final line pressure. This is just kind of a general procedure for adjusting regulators, but especially whenever you're adjusting bulk oxygen regulators, these regulators are feeding normally a pretty large piping system, so you want to adjust these very slowly, and you're also going to want to do them one at a time. So if you do have both regulators online, you would need to shut one of those off, shut the inlet and outlet valves for one of those regulators, and then you're going to want to adjust the other regulator that's obviously still online. Next, you'll want to turn the handle of the regulator about 1/4 turn clockwise every 5 minutes. But it's just going to be important to keep an eye on that final line pressure gauge after you make that 1/4 turn, and then give it at least 5 minutes to kind of level out in between each time you adjust it. So every time you turn it a 1/4 turn, you would want to wait 5 minutes prior to turning it again. It's also a good idea to have someone located inside the building when you're making these final line regulator adjustments for oxygen, it is possible you could have an area alarm sensor that could be out of calibration, could be reading a little high. So you would want to just have somebody talking to you while you're outside raising it, kind of giving you an idea of what they're seeing inside. Anytime you adjust the final line pressure, just be sure to monitor that pressure very closely for certainly the next 24 hours after you've adjusted it, just to make sure that you don't get any kind of drift up that would cause you to have any kind of high line issues or any other major problems. We've seen facilities go up above 60 at the bulk site itself if you have such a high demand that the regulator might call for that to be dialed up that high. Just keep in mind that your final line relief valves located right downstream of those regulators are going to be set at 75 psi. So as a result of that setting, we do not recommend exceeding 60 to 65 psi on the final line regulator at the bulk pad. Okay, so one of the most common questions we've been receiving is how many ventilators can I install within my facility? This is not an easy question for us to answer as medical gas verifiers. Respiratory therapists don't always know the answer either because they don't have the expertise of the entire systems like we might have. But most verifiers don't have the expertise to know, clinically what these patients are going to be needing. The best way to approach getting an answer to this question is a joint effort between the medical gas systems expert and the respiratory therapy department. So what we're suggesting to do is to break down that request. First of all, find out what specific zones or areas these vents will be placed into, these ventilator units, and then ask the facility if they know how many ventilators they have access to, how many ventilators might they be trying to put into these zones. Lastly, if you can find out what the specs are of the ventilators that will be in use, you can use those specifications to find out more information, such as if the ventilator uses oxygen and medical air, maybe the ventilator just uses oxygen, maybe some of the ventilators are BiPAP machines that they're calling ventilators. So you just want to find out a list of exactly what all equipment they're going to be using. And the next, interface with the respiratory therapy department as much as possible. Ask what they've seen as maximum constant inspiratory flow rates. Find out what the percent O2, the FiO2 setting has been on the patients that are experiencing these max flow rates. And then what the average breaths per minute have been. From all that, you should be able to figure out a decent LPM rate, hopefully a constant LPM rate that you can apply to the areas they're wanting to put these patients in. Ask about as-built drawings that they may have access to, that the facility may be able to show you to review the piping system. Just knowing the zone valve size does not give you the full picture of of how much flow you can sustain in a given area of the facility. It is one piece of the puzzle, but the feeding pipeline into that zone plays an equally important role, maybe even a more important role. So what are some other resources for figuring out how many ventilators can be installed? A great resource was just published by Mark Allen with Beacon Medeus in the MedGas Insights publication, issue 8 from April 2020. That is one. Kaiser Permanente put out a document about this in late March that they have made available to the community. The Puritan Bennett 840 ventilator calculator is specific to a ventilator. It can help determine the standard cubic feet of oxygen that is being used per day based on some information that the respiratory therapist would have to input into this spreadsheet. And then the last way is to run actual flow tests in zones where additional ventilators are expected to be put into use. Another question we got is how many ventilators can be supplied from a 1/2 inch medical air and oxygen zone valve. Like I mentioned earlier, this is going to depend heavily on the pipeline that is feeding that zone. So you can't answer the question just knowing what size the zone valve is by itself. There is a document that lists 212 liters per minute on a 1/2 inch zone. There's another document I've seen that lists 260 liters a minute on a particular zone. But actual flow tests can show you a snapshot of, say, how much flow it takes to go from 50 to 45 psi and then to maintain that. All right, so we wanted to share with you a actual flow test that we performed at a facility on a 1/2 inch oxygen zone valve. That particular zone served an 8-bed unit on the 5th floor of the facility, and that was served by a 1-inch service line on that floor. So the procedure we used was just to take flow meters, connect them in all 8 rooms to an oxygen outlet in all 8 rooms, and then we set each flow meter to a continuous flow of 110 to 120 liters a minute, and that gave us a total continuous flow of around 880 to 960 liters. We started off, before we opened any of the flow meters up, at 49.5 pounds, and the pressure dropped in that zone before it stabilized. It went down to between 41 and 42. It was somewhere in that range. It would kind of drop a little bit and come back up. There were 3 other zones on that floor that we also checked the static pressure on those zones as we were dropping in the 4th zone, and those zones all went down to about 44 psig. Those were also 1/2 inch zone valves. All 4 zones on the floor were 1/2 inch. One other thing to note there is that they did have ventilators in use on the floor below. On the 4th floor, they had about 14 ventilators online at the time we were performing this testing. I don't know any other ventilator stats as far as usages or FiO2 or anything else. I just know that it was an LTAC floor below this one that had 14 ventilators in use. Something else that we need to be aware of are what other respiratory devices might be in use while we are trying to help facilities calculate flow for number of ventilators or just COVID patients in general. This detail 2.1 came from the Beacon-Medeiros MedGas Insights article that Mark Allen wrote, and it lists 5 other respiratory therapy devices besides standard invasive ventilation, which is also listed, that also could have high flows on the oxygen and medical air systems. And it's just things that we need to be aware of and that we need to ask the respiratory therapy departments about to see if they're using these devices either for COVID patients or maybe if they expect to be using them for maybe non-COVID patients that they just know that they may have a normal usage on. So while we're calculating flows, don't be so focused just on the ventilators that COVID patients might be using that you lose sight of the other devices that might be in use from other patients, whether or not they have COVID-19. Just try to get as full a picture as possible of the total demand on the system when offering advice about max flows that they might be able to achieve in one zone or another. Another question we've been getting a lot is how much flow of medical air and oxygen does a ventilator use? Both of these gases are hooked up to the ventilator, so the question is, based on the percent oxygen setting on the ventilator, how much of that how much of the medical air system is being used and how much of the oxygen system is being used. This table 2.2 is also from the Beacon-Medeiros MedGas Insights article. That lists the ratio of medical air to oxygen based on the FiO2 setting. On the right, I have taken a 45 liters per minute total flow and then just shown you, for example, if it was a 30% FiO2 setting, the oxygen flow would be about 5.2 LPM. The medical airflow would be about 39.8 LPM. Added together, that would give you your total 45 LPM flow that the ventilator might be showing. Do all ventilators use both medical air and oxygen? And the answer is no. All ventilators do not use medical air and oxygen. Some of them use just oxygen, and some of them use both. For this reason, it's pretty important to try to get a list of all the different devices they're going to be using, or ventilators that they're going to be using to combat a surge in COVID-19 patients. And then, like I mentioned earlier, try to learn what other treatment options other than ventilators that the respiratory department might be using to treat these patients. Here's a slide showing some stats that we have just pulled from different ventilators that facilities have told us that they're using. And then we have broken these down into ventilators that only use oxygen and then ventilators that use oxygen and medical air. The other thing that I've included here is the max flow listed from the specification, as well as the low operating point and the high operating point from the specifications on that specific ventilator. It's important to realize that these max flows are max peak flows and not typically max continuous flows. So how many ventilators can my existing medical air compressor supply? First, consider the age of the medical air compressor system in question. The older that a system is, the less efficient it will likely be compared to what the manufacturer stated it would produce when it was installed or when it was purchased. And then also the condition, really the maintenance record on that system can play a huge role in how efficient it is now. Refer to the manufacturer of that system for capacities. Again, maintenance factors, age and condition of the systems will definitely have an impact on what the manufacturer said it could produce on day one. We've included a formula here to help you determine what the current usage is on your medical air compressor system. To use this formula, you will need to observe the system at a time when the compressors are not running, and you'll need to gather the information of the variables listed in the example below, just the size of the receiver in gallons, and then the difference between the when the lead unit comes on, when the lead unit shuts off, and then the length of time it takes for that lead unit to achieve that delta difference from on to off. Some of our verifiers have expressed that they have had issues when connecting ventilators or other high flow respiratory devices to older outlets. The ventilators themselves would be going into alarms. We've just provided in the next few slides some of the outlets that have had issues. Primarily this is just due to smaller diameter pigtails, and most likely smaller diameter piping also feeding those outlets. So here you can see there's some older outlets by Allied or Chemtron, the 148, 238, 248 series, also 146, 236, 246. That would just be the DISS version of the same outlet. And then also the Omega Diamond 1, those would also have been outlets that typically would have had quarter-inch pigtails, so the piping system serving those may also have been undersized. And then Puritan Bennett, the Series A, Series 73, and Letharge series, those again had smaller pigtail sizes and could very possibly have smaller distribution pipelines feeding them. So just take note whenever you're dealing with older outlets, you may want to do some flow testing to make sure that you can achieve the peak flows that the ventilators may require. We have had some verifiers ask us about annual med gas testing requirements. The first thing you're going to need to do is check with the facility in question. At this point, each facility has their own, COVID-19 guidelines that they're following, so they may or may not be letting contractors on site to perform that work. The next thing to consider is the health and safety of your own employees, depending on if any of your employees have any pre-existing conditions or things that you might have to worry about. You'd obviously want to consider that. And then the third thing is to make sure you educate facility directors about the waivers that are offered by CMS. There's an 1135 waiver, and then also most accrediting organizations have stopped doing their on-site surveys. DNV, Joint Commission, at least these two have stopped any on-site surveys for now. So what can we do to ensure our med gas systems accommodate the increase in ventilator patients? There are quite a few ways that the capacity of these systems can be increased or supplemented to deal with additional ventilator usage that might be required by patients with COVID-19. These can be broken down into 4 separate categories, and the first way would be to increase the existing system capacity. Second would be to supplement existing systems to just deal with surges in usage. Third would be to backfeed different areas of the hospital as needed to help accommodate for overconsumption in specific areas. And then the fourth way would be to just install separate supply systems entirely for temporary surge areas. There's been a lot of discussion on the increased use of oxygen because of the increase in ventilator usage that COVID-19 patients have required. It's been reported to us that these infected patients have been using an 80 to 100% oxygen setting due to the nature of the virus affecting the respiratory system and causing respiratory distress. So the oxygen systems are the primary focus of the information that we're providing here, but medical air can also be impacted due to the fact that as patients are first going on the ventilator or maybe as they're coming off the ventilator, that usage may be, that FiO2 setting very often might be less than 80 to 100%. So we've also given some advice on medical air as well. So there are a few different ways to increase the capacity of the oxygen system. They include installing temporary supplies to add additional capacity. This could be connected to the EOSC. It could also be connected to the auxiliary source connection, which is normally located at the bulk oxygen pad. Another option for temporary supply, if the facility has a separate hyperbaric oxygen supply system, that separate system could be connected into the auxiliary source using long flexible connectors on the oxygen bulk pad. So what are some ways of increasing the capacity of the existing medical air systems? A lot of facilities have multiple medical air systems. It is a great idea when these systems can be interconnected via bypass piping. This allows for the systems to work together to help minimize any disruption that might happen due to a surge in ventilator usage. But just keep in mind that just because a facility has multiple medical air systems, that doesn't mean that they are necessarily interconnected. This needs to be verified if they were interconnected at the time that they were installed, or if they weren't interconnected, then that is something a facility could look at doing if they're experiencing issues, would be trying to run that bypass piping now to connect these systems, these two or more medical air systems together to help increase the overall capacity of medical air in the entire facility. Another option is to allow the lag compressor to run as needed. Typically the lag compressor never comes on unless there is a failure in the system. In this case, since we could be using as much as 80, 90, even 100% of the design calculated flow that the air systems were designed to, it may be necessary to let these compressors run with the lag compressor running. Keep in mind that if you are going to allow your medical air system to run in a lag state, it should only be done on a temporary basis. So how do we supplement capacity of existing oxygen systems? One way would be to install temporary supply in the EOSC or at the auxiliary source connection at the bulk tank, like we mentioned. This could help prevent large pressure swings that can occur when nearing system capacity. Another option for temporary supply is using the hyperbaric supply system and connecting that to the auxiliary source connection using flexible connectors. Another way to supplement either oxygen or medical air for a hospital in certain areas is to set up what we would call backfeed rigs. We use these often during planned shutdowns for medical gas systems. The way we typically do it in a backfeed scenario would be that because the system is getting shut down for some tie-in, the zone being backfed would normally be shut, the zone valve would be shut, and then a temporary supply would be located inside of that zone and would just feed that zone. In this case, for COVID-19 response, we would not be shutting the zone, but we could still utilize temporary supplies of gas with a backfeed regulator hooked up somewhere nearby the zones that are experiencing the surge in usage. And if the system has a surge in usage that would cause the line pressure to drop, we would set these backfeed regulators up just below normal line pressure so that as the system pressure begins falling, the temporary backfeed supplies would feed into the line to help mitigate that falling pressure. So there are several temporary patient areas that are being constructed all over the country right now. There's been an increased need for temporary supply systems as a result. So we've seen patient tents outside of facilities. We've seen conference rooms converted, lots of repurposing of other areas just to try to help accommodate the surge in patients. Temporary supply systems really should only be installed when the primary hospital systems are not available. They will probably be a lot different than the main hospital med gas supply systems, and they won't have all the same redundancies, will not be able to function quite the same way. So these are really only to be used in emergency situations, or like the name suggests, just in temporary situations. And these temporary supplies can consist of high pressure cylinders, portable liquid dewar tanks, oxygen generators, or other portable supply systems. So can I use other areas of the hospital for ventilator patients? There are many areas of the hospital that are not critical care. They're probably just regular patient or med-surg areas. However, with the changes brought about by COVID-19, these areas are now being considered to use as ICU spaces or critical care spaces. So there's some things to keep in mind. First of all, these areas may not have been designed for critical care equipment like ventilators. And there are a specific set of design standards that are followed when an ICU or a critical care area is being built. And those design standards for critical care are going to be, like I mentioned, very different than non-critical care. One of the major things that's very different is for critical care areas like an ICU. Typically, the diversity factor would be at 100% versus a med-surg wing. The diversity factor would be at 10%. And whenever we talk about diversity factor, what we're talking about are how many of the available rooms or outlets, if you're putting in 80 of them, how many of those are expected to be in use at a time. If it's 100% diversity factor, you would expect that all 80 of those outlets would be in use. Whereas if it were a 10% diversity factor, only 8 of those outlets might be in use or expected to be in use. So the main reason that this diversity factor becomes so important is because the pipe sizing leading to those critical care areas or non-critical care areas is going to have a direct or is going to be a result of the diversity factor that those areas were designed under. Just because a higher diversity factor will necessitate having larger pipe sizes. So do you need to put area alarms in zones that will now be used to supply ventilators? If you have a zone that has a change in use from a med-surg floor or a non-critical care space to a critical care space, the right answer is yeah, you should put an alarm panel there if possible. One way of accomplishing this would be to install a temporary alarm panel that could monitor those med gas systems while that area is being used for critical care. The facility could also implement interim life safety measures that could include actual rounding where a staff member is actually checking the line pressures in those zones that do not have alarm panels, and then they would just need to be documenting that as they went along. So that leads us to the question of how we deal with the existing code and regulatory requirements during the COVID-19 pandemic. The area alarm discussion that we just had kind of touches on it, but really what we're wondering is do these systems and the emergency operations need to meet current code and regulatory requirements? Obviously, in a perfect ideal world, they would, but we need to keep in mind that the number one priority is keeping patients safe and preventing death. That is the goal here. So that's why you've seen CMS and accrediting organizations such as Joint Commission and DNV have put out statements that they've relaxed many of their requirements while this is going on, including not even showing up to do normal surveys. I mentioned earlier CMS has issued a waiver for some of the Medicare and Medicaid requirements. That waiver is 1135. We listed a link to it earlier. I encourage you to download that and read it if you haven't yet. Also on the ASHE website, if you search waiver 1135 under the ASHE forums, there's a lot of good discussion under there now about facilities sharing what they have submitted to get waivers on and what they have received or gotten approval from CMS, basically that they've allowed those waivers to go through. So the main question is, what do we need to worry about regarding the code requirements, specifically NFPA 99? And 99 does have a few statements with regards to the application of this code, and it's in the application section in Chapter 1. And basically they state the following, that the healthcare organization shall ensure that policies are established and maintained that permit the attending physician to satisfy the emergency needs of any patient that supersede the requirements of this code. So basically, the emergency needs of a patient, the attending physician can throw the book out the window if he needs to, if it means that it's a matter of life and death, and that's what it's going to take to save that patient. Keep in mind, each special use shall be clearly documented and reviewed to attempt to have future similar needs met within the requirements of the code. Where the facilities may be deviating from the code, they do need to document those and set up a review time to figure out in the future how they could, what systems they might need, could have had in place to have been able to avoid having to step outside of the requirements of the code. So keep in mind that essentially the facility does have an exemption from code requirements in emergency situations if needed to keep patients safe. But there does need to be a documentation and approval process for any systems that are going to be non-compliant. They shouldn't just be arbitrarily waiving what the guidelines or the code say without having documentation and an approval process for why they're doing it and why they're approving it. And then we can play an integral role in the process by identifying what those requirements are and which ones might be burdensome and unnecessary, along with the ones that are absolutely going to be necessary. And then those items need to be addressed by the AHJ, which could be the responsible facility authority at the hospital in these cases. So what role are we as verifiers being asked to play in these makeshift temporary facilities? And this goes back to the compliance question that we really just talked about. Per NFPA 99, in order for systems to be used for patients, they shall be verified prior to being put into use. And that doesn't matter whether it's a temporary system or permanent system, they're still supposed to be verified. However, if the responsible hospital authority or the AHJ deems that that requirement's unnecessary or overly burdensome, it just should be documented that they're going to skip that requirement. And ultimately, the responsibility for this is going to remain with the hospital, so they are the ones who really are going to be responsible for having their documentation in order and approving anything that they step outside of with regards to NFPA 99 requirements. The last thing we wanted to cover were just a few recommendations that we had come up with for maximizing medical gas system usage. Some of these will seem pretty obvious, but nevertheless we wanted to share them with the community as a whole. So under piping and system concerns, we would like to try to see people pick areas of the facility that have the largest pipe sizes available, especially for oxygen and medical air. And then while doing that, also considering the distance from the bulk oxygen or medical air sources and picking areas that are near to the source with shorter runs of piping if possible. Setting mainline pressures for oxygen and medical air to a minimum of 55 psig. That is the high end of the normal range listed in NFPA 99, so there's no reason that everyone can't go ahead and be set that high for oxygen and medical air. And then ensure you've located the EOSC for the facility, or that the facility has designated someone to locate that EOSC, that they have access to it. Ensure that it's in good working order. If it has not been tested recently, if they can't tell you when the last time it's been tested, then the recommendation would be to procure a cylinder of oxygen and connect that with a regulator. And then you could just raise it up above line pressure enough to be able to see the line pressure inside the building go up a pound or two. That will just verify that you don't have any issues with the check valve or any of the other components within the EOSC assembly. So regarding the ventilator concerns with maximizing medical gas system usage, ask respiratory what all information they can give you. If they know what ventilators max flow rates are, what actual COVID patients max flow rates are. Some of the respiratory people have been really good about tracking that and being able to give us data about, this is how many cubic feet per day these 10 COVID patients used, and then we're able to create kind of matrices based on that. There's also the Beacon Medeus and Kaiser Permanente documents that you should review. Read those and digest what's in there. Try to use that as part of getting a complete package here, a complete picture of what's going on. And then consider if the ventilators need just oxygen or if they're going to need oxygen and medical air to operate. That will have a big impact on whenever you're trying to decide how to maximize med gas system usage. And then under backup plans, what is the plan if the medical air system has a failure? It's something that people need to be thinking about if they haven't already. They should have already thought about this, but in the event that they haven't, is there a second system that's cross-connected via mains? If so, perfect. That kind of answers the question. But if not, is there a temporary medical air system available in that area? Do they know of a vendor or somebody else who could supply that? And then the last option there would be medical air cylinders. That's obviously not a great long-term option, but it can, like we mentioned earlier, it can help with surges in use as far as maintaining line pressure. And then you could find out if there are any locations inside the facility that can serve as spaces for supplemental oxygen and air to be staged and connected. We're talking about cylinders here, obviously. So if there's biomed rooms, respiratory rooms, other rooms that maybe aren't patient care spaces that will be open, that you could stage some oxygen cylinders in temporarily and have a regulator there just in case they had a need to be used or to go online. That's something to think about and to kind of outline now. And then if the EOSC must be utilized, what's it going to take to connect to that EOSC? Is it a 1-inch inlet? Is it a 2-inch inlet? Are all the bushing reducers that are going to be necessary? All the other fittings? Just ensuring that the facility has those, so in an emergency situation, you're not looking for fittings. And then there are some daily rounding tasks that facilities can implement now, just to try to keep an eye on the usage on their systems. First of all is the status of the bulk oxygen vaporizers. As we mentioned at the beginning of this, that is kind of the point in the system that's going to possibly create the biggest flow restrictions. If there is a large ice buildup, then the entire system is going to start to suffer, and the flow rates that the vaporizer is rated at will not be achieved if the level of the ice buildup becomes too great. The main line gauge reading at the source, that's another good thing to keep an eye on each day, just to write it down. And then pressure readings inside the zones with the heaviest usage. This is a good one to keep a track of each day, because if you start to see that trending downward, that's a good indication that for the facility that they're going to need to contact their med gas experts or their bulk oxygen suppliers, so that they can get as early of a warning as possible that they may have a problem within their systems. So with the medical air compressor, just check it each day and track the following: how many compressors are running, how long does the compressor run when it comes online, and how long does the system rest when there are no compressors running. If you can get facilities to just keep a log of all of these different items, and with the bulk oxygen vaporizer, the best log to keep really would just be a picture log. Most everybody has a camera phone now, so if they could just go out there and snap a picture from the same place, or maybe get a couple angles of the vaporizer each day, that way whenever the bulk oxygen supplier comes out, they can kind of see the icing level over the past week or 2 weeks or whatever it's been. And then on the other items, whenever the med gas experts come out to help with possible issues that may be happening in the system, these readings and these logs will just provide more data for them to be able to better assist the facility and make sure they get back up and running ASAP. And that's all for this one. We just want to encourage everybody to be safe, stay safe. We will get through this. It will end. Things will go back to some semblance of normalcy. And we just encourage everyone to help their facilities out as much as possible. And if you have any questions, please let the board know, and we would be happy to help out any way we can. Thank you.